Thanks, Jamie. Okay, let's go to Aaron. Aaron, can you hear us? Okay, we will come back to Aaron. Elena.
Hi, good morning, everyone. My name is Elena Shablowski. I use she, her pronouns. I am a dentist and dental director at La Clinica, which is a federally qualified health center in Medford. Thanks.
Thanks, Elena. Aubrey.
Hey, good morning, everyone. Aubrey Corbett, primary care doctor with Central City Concerns Blackburn Center and naturopathic doctor, and I am a committee member.
Thanks, Aubrey. Daniel.
Good morning, everyone. I'm Daniel Ornelas, and I serve as a dental program manager at the Virginia Garcia Memorial Health Center. Thank you.
Thank you, Daniel. Larissa.
Larissa Mejia Medina, Quality Improvement Nurse Director at Road Community Health in Medford.
Thank you, Larissa. Gabby.
Good morning, everyone. My name is Gabby Carrillo. I am the Medical Assisting Program Director at Sumner College and now also the Director of Clinical Placement for the nursing program as well.
Thank you, Gabby. Manu.
Hey, good morning, everyone. Manu Chaudhary. I serve as president of Capital Dental Care, a dental care organization in the state of Oregon. I feel like I say this all the time because I feel like I have to, but I'm going to continue saying it. So I also serve in other committees as well. One of them is the Health IT Oversight Council, co-chair of the HIA work group, and a member of the Metrics and Scoring Committee. Really happy to be here. And Laura, I'm quite surprised that a year flew by already, that your term is already ending. I kind of feel like it just started, but maybe I hit my head on the way in this morning. But anyhow, good morning, everyone.
Good morning. Thank you. I know it flew by for me too. Let's see, Alicia.
Hi, good morning, everyone. I am Alicia Jackson. I'm a new committee member. I am a family medicine physician with OHSU and also the medical director and associate program director at OHSU Health South Hillsborough Primary Care Clinic.
Thank you. And Coy?
Good morning, everyone. My name is Koi Vu, pronouns she, her, hers. I am also a new committee member. I am the executive director of the Coalition of Community Health Clinics. Thank you.
Thank you. Ian?
Ian Strauss. I use he, him, and L as pronouns. I am the special projects coordinator at Whitebird Clinic, a federally qualified health center in Eugene, Oregon.
Thank you, Ian. Dr. Hemmings?
Hi, Dr. Rosemary Hemmond, she, her pronouns, owner, CEO of Black Therapists and Company, which is mental health wellness in Beaverton. And I'm also on faculty at OHSU School of Dentistry.
Thank you. And Judy?
I'm Judy Geiger. I'm the Vice President of Patient Care Services at Columbia Memorial Hospital in Astoria.
Thank you. And did I say Bhavesh yet?
No, good morning. This is Bhavesh Rajani, he, him pronouns. I work for Pacific Source in Marion and Polk counties, doing Medicaid work, and have a background in family practice. Good morning.
Thanks, Bhavesh. And Aaron, are you with us yet?
Yes. Good morning, everybody. Aaron Hines. I'm the CEO at the Yellowhawk Tribal Health Center, owned and operated by the Confederated Tribes of the Umatilla Indian Reservation out here in Eastern Oregon.
And did I call in Gabby? Okay. And
yes,
then, okay, perfect. Thank you. And then I wanted to take the opportunity to just recognize Brenda Johnson and have her introduce herself. Brenda is our wonderful liaison to the Oregon Health Policy Board, and we very much appreciate her being with us.
Thank you, Laura. Brenda Johnson, I use she, hers. My pronouns, and I also serve as the CEO of La Clinica, a federally qualified health center in Southern Oregon. And it is my pleasure actually to represent the hard work of this committee and the staff and leadership to the Oregon Health Policy Board. Thank you.
Thanks, Brenda. And Mark, I know we have a number of OHA staff here. Do we want to take a few minutes and have them introduce themselves?
I think that would be great, Laura. And if you'd like to call on us in turn.
We could, and we'll start with you.
Okay, great. Good morning, everyone. I'm Mark Overbeck. I use he, him pronouns, and I have the privilege of serving as the lead staff among the many, many staff at OHA who support the committee.
Thank you, Mark. Andy?
Thank you, Laura. My name is Andy Davis. I'm the lead research analyst for the Healthcare Workforce Reporting Program, and we're happy to be on your agenda today.
Thank you. Brian? Can you hear us, Brian?
Yeah, can you hear me?
Yes, we can now, yes.
Yes, good morning. My name is Brian Staffy. I'm a policy and communications analyst. I just started on Monday.
Thank you, Brian. Welcome. Jill?
Morning, everyone. I'm Jill Boyd. I'm the Healthcare Provider Incentives and Project Coordinator, and I'm with the Healthcare Providers Incentives Program.
Thank you. And Dawn, I see you're here. Dawn Montner?
Good morning, Dawn Moutner, she, her, Aya. I serve as the Medicaid Medical Director, and I'm delighted to be with you for a little while today. Thank you for the work that you do.
Thank you, Dawn. John McElfresh?
Good morning, committee members. John McElfresh, and I am the Oral Health Workforce Coordinator within the Primary Care Office at OHA.
Thank you, John. Lauren?
Hi, I'm Lauren. I use she, her pronouns, and I'm a graduate intern with the Clinical Supports Integration Workforce Unit. Thank you.
Thank you. Meredith?
Hi, I'm Meredith. I am a research analyst with the Healthcare Workforce Reporting Program.
Thank you. And Neelam?
Hi, good morning. My name is Neelam Gupta, she, her pronouns. I am in the Clinical Supports Integration and Workforce Unit.
Thank you, Neelam. Piper?
Hello, everyone. I am Piper Block, she, her. I am the Research and Data Manager for the Office of Health Analytics, overseeing the Healthcare Workforce Reporting Program. Thanks.
Thank you. Sarah?
Hi, I'm Sarah Grusing. I use she, her pronouns, and I'm a data analyst on the Healthcare Workforce Reporting Program and also for the Behavioral Health Workforce Initiative. Thanks.
Thank you. Terrence?
Grand Rising, Terrence Saunders, he, him, his for pronouns, and I'm the Behavioral Health Workforce Equity Coordinator in our Behavioral Health Workforce Development Team.
Thanks, Terrence. Suzanne?
Hi, good morning. Suzanne Cross. I'm a senior policy analyst. I use she, her pronouns, and I'm with the Office of Health Policy, also just started on Monday.
Thank you. And Leah?
Hello, everyone. I am the Healthcare Provider Incentives Program Coordinator working in the primary care office.
Thank you. Is there anyone, any committee members that just joined that I missed? I don't think so. Okay, any OHA staff that I missed that want to introduce themselves?
Yes, I'm Joe Bergeron, he, him pronouns, Behavioral Health Workforce Pipeline Coordinator in the Primary Care Office. Thank you.
Thanks, Joe. I didn't see an OHA by your name, but I thought,
yeah.
oh, I know Joe's with OHA.
Thanks.
Thank you. Liza?
I'm Liza Root. I am the Health Professional Shortage Area and National Health Service Corps Specialist. I use she, her pronouns. Thank you.
I think I've gotten everybody now. Perfect. Oh, right. Okay, so next on the agenda, we did that very timely. Next on the agenda is the approval of the November and December 2022 meeting summaries. So I trust everyone had a chance to review those before the meeting this morning. We're going to do, I'm going to vote for approval on those separately. So are there any changes or additions to the November meeting minutes summary? Okay, none being said, can I get a motion to approve the November meeting minutes summary, please?
I make that motion. This is Manu.
Thank you, Manu. And can I get a second?
Second. Daniel.
Perfect. And then committee members, all those in favor, if you can either raise your virtual hand or raise your real hand or give us a thumbs up, that would be awesome. Hopefully someday we'll be back in person and we can see everybody's hand in person. All right, is there anyone opposed? Aubrey, I don't think you're opposed, right? Your hand's up, but you're not opposed. Okay, perfect. All right, thank you. Those minutes are approved. Moving to the December 22 meeting summary minutes. Any additions or changes to those minutes? Okay, seeing none, can I get a committee member to make the motion to approve those minutes, please?
Sorry, go ahead.
Whoever. It's been moved.
Okay, and can I get a second? Maybe Gabby, you could second.
Yeah, I'll second.
Perfect. Thank you. Once again, thumbs up, virtual hands, real hands for the approval of the December 2022 summary minutes. Thank you all. Anyone opposed? I'm gonna wait for the hands to go down because I don't think anybody's opposed. Sometimes those virtual hands stay up a little while. Okay, none seen. Those minutes are approved as well. And let's go back to the agenda here. Okay, 9:45, we are back on track, exactly. So now we are at the period of the meeting where we do accept public comment. And I didn't get an email from Jamie saying we had anyone that had public comment. So I will open it up. I know we have quite a few folks on the meeting this morning. So if you would like to give public comment, we could probably maybe give 2 minutes for public comment. If you could raise your virtual hand or speak up or thumbs up, that would be great. And I just want to remind everyone, we actively listen to the public comment. We just won't be able to actually respond to the public comment at this meeting. If you would also like to submit written public comment, we will absolutely take that into consideration as well. And I did see Russell's hand go up first. So Ben, will come to you after Russell. And Russell, I invite you to go ahead and you have the floor.
Thank you. I'm in my very cold office. I will take a brief time, and I want to thank the committee for taking the time to hear some public comments. I am a practicing physician assistant in primary care and addiction and recovery services, and a member as a director at large of the Oregon State PA Association. We recently identified that the state's hospital for mental health in Salem does not employ physician assistants. And in looking into that, we found that there's a greater obstacle to employing physician assistants in psychiatry and psychology through the state and county departments. When we contacted the OHA about the lack of postings for physician assistants in those arenas, we were told that it involved contracts and union negotiations and a scope concern, and that we could apply for non-medical based positions, such as receptionists or scribes or otherwise, but that we could not be employed as providers in those arenas. And we do have written emails from OHA on that. So we have a letter that we've written kind of summarizing some of those details, but wanted to bring it to the attention of this group, knowing that hopefully it would fall on sympathetic ears. knowing that Oregon is one of the least accessible for mental health services and recovery services, I think that PAs can offer a great amount of experience and support in increasing provider access and patient support. And that's all I have.
Thanks, Russ. If you wouldn't mind, would you put your contact information in the chat, please? So we can have that. That would be awesome. And you did say you had a letter. Did you submit that letter?
Ben Johnson drafted the letter and submitted it. He could probably give you details on where it was submitted specifically.
Perfect. Okay. Thanks, Russ. And Ben, I will turn the floor over to you.
That's okay. Taylor is with me, obviously, and he covered everything. Our lobbyist, Taylor, got the letter to you. We'll make sure that that he knows how to get it, that you know how to get a hold of him.
Okay. All right. Is there anyone else that has public comment? You can just raise your hand, or I don't see any hands up. So if you are on the meeting and you would like to go ahead and just speak up and give some public comment, we are happy to let you do that. Okay, I am not seeing anyone else. Okay, once again, submit a letter if you would like, and we will go ahead and move on to our Oregon Health Policy Board and OHA updates, and I will turn it over to Brenda.
Thank you. It's great to be with you all. The Oregon Health Policy Board met yesterday and had a pretty full healthcare workforce agenda. There were 2 items that Neelam prepared along with our consultants from OSU. And so I know this group has really done a lot of heavy work to prepare those materials and the conversations that went with them to the board overall. There were a few questions of follow-up, specifically around the healthcare provider incentive fund and the reallocation or redistribution of resources under that program that we'll be taking back to the board next month. And then also, you know, I just want you to know that I want to continue to advocate that the workforce priorities remain on the board's agenda for some period of time. And the board is currently in a process of evaluating its priorities, and as I said yesterday, I cannot imagine that board making decisions to not include workforce as a major strategic imperative for the state moving forward. So I just want to let you know that that transpired, and I'll be continuing to work both on the scene and behind the scenes to ensure that we continue to keep a level of attention for the importance of both the committee work and the staff work to continue to move the dial in the areas that we always talk about. So so I think that is important to share with the community. We also had an opportunity to have a conversation with our new director, James Schroeder, who shared a bit of his background and perspective with the board. It was his first day, God love him, and the first meeting of the day. So, you know, he came in, I would say, pretty fresh, and also made a point to really establish, I think, himself as a former healthcare provider, really understanding the complexities of serving populations and communities. And one of my questions for him was around staying the course on the efforts and initiatives around health equity, to which he absolutely guaranteed that, you know, there was nothing that was going to sway us off course of the important work that we've been doing in that territory, you know, by Pat Allen, his predecessor. So that was comforting. And I think, you know, there's a big challenge, as we all know, around the state leadership and finding the right people and talents to serve in these really critical roles. So there's a lot ahead of the agency itself. James also shared a bit around his priorities, you know, specifically around ensuring that our redetermination work goes smoothly as possible, given the end of the public health emergency. And I think also just continuing to shore up the agency in terms of its priorities and focus areas. So there's a lot there. Let's see, what else do I want to say? We also received a report on redetermination or unwinding continuous eligibility for the Oregon Health Plan in a way that we're thinking as a state about implementing strategies that automate more often, as well as the communication strategies to do really comprehensive outreach and engagement with people as that eligibility redetermination will happen over the course of a year. So we receive more news about that. As I said, we reviewed the letter from this committee, and thank you to Laura and to Mark for, I think, articulating a really cogent interpretation of the OSU's needs assessment. And in that priority, for just as a reminder for all of us, what we talked about and what we shared with the board yesterday was the importance of diversifying the workforce and really paying close attention to workforce well-being and resiliency. It's funny, in fact, Laura mentioned this also. It's on one hand, we talk about the importance of workforce resiliency, and then later in the agenda, we have a conversation about CCO procurement and the important administrative work to think about recontracting for CCOs beyond CCO 2.0. And so I want to continue to remind ourselves in the collective about how those worlds coincide with one another. So just know that's part of what's in my mind and heart as we continue to move forward with the agency. So I'll pause there, ask Laura, who I know was in attendance, Mark, Paul, I think I saw your name on the hit list too, if any of you have other updates from the board itself or anything that you'd like me to focus on. No.
Mark, did you have anything?
I did not. I thought that was a great summary, Brenda, of the recent board activity.
Great. Thanks, Mark.
Yeah, and I think the only thing I would add, Brenda, is you know, there was a lot of recommendations in the healthcare workforce needs assessment. I think there were 30, if I remember correctly. There were a couple that stood out to us that we pointed out in the letter. One of them being, you know, focusing on expanding the diversity of the workforce. And the other one was trying to focus on the resiliency and health and wellness of the workforce. And in the letter, we talked about that our healthcare workforce is the heart of our healthcare system. And if we don't have a healthy and well and resilient workforce, I don't think we're going to have healthy Oregonians. So I also mentioned, and you know, this committee has heard me say this before, you know, potentially thinking outside the box of normal thinking, you know, and not that wages and that's all not important at all, but you know, one of the things I mentioned in the letter was childcare, and my CCO serves Curry County. Currently in Curry County, they have declared a state of emergency for childcare. There is no childcare available in Curry County. And if you know, I know personally, my daughter-in-law works for the state of Oregon, and if she does not have childcare, she cannot go to work. That is statewide, you know, it's obviously nationwide, but statewide, if our healthcare workers don't have childcare, they can't go to work. Of course, she has Nana who fills in as much as she can, but that's not a solution. So just, you know, trying to think on those terms outside the box, what we can do to support these healthcare workers. The other thing in Curry, and I don't mean to focus on Curry County, but it's a focus of mine. There's no housing. There's absolutely no housing. In Gold Beach, they built 12 new housing units. Not one of them was bought by a local person. They were all bought by outsiders coming in for vacation homes. And that's, you know, again, that's their prerogative, but we can't bring healthcare workers into this county if we don't have a place to put them. We've lost behavioral health providers because they can't find a place to live. So we just kind of need to broaden our thinking and see how we can support this workforce, looking at different ways. So that was something that we talked about. I'm looking forward, even, you know, as I'm coming into being past chair, that doesn't mean my work is going to finish. I am going to support this committee as much as I can in the future. So, you know, I would welcome my vice chair, incoming chair, Paul, if you had any comments on that, Paul, and if, you know, if anybody on that respect, and we can move forward, but I just wanted to open up since we have just a couple minutes. Paul, did you have anything? No. You're muted.
Only that it'd be great if you'd stick on as chair for another year, Laura, because you've been doing such a great job. We'll miss your masterful work with these meetings.
Well, I've enjoyed it. I've enjoyed it a lot. Okay, if not, we will, thank you, Brenda, for that update. And, you know, I would encourage anyone, any of the committee members here, if you don't attend or listen in on the Oregon Health Policy Boards, I have done it every month for I don't know how long, and I learn so much at those meetings. And if you really want to dive into some of the work that's being done by the Oregon Health Policy Board and how they shape the future of, you know, what we're doing in Oregon, I would really encourage you to listen into those meetings on Zoom, because you really will learn a lot at those meetings. And so I really appreciate that policy board and the thinking and voicing the concerns and the important opinions that they have. So thank you for that. And Mark, are there any PCO updates at all?
I'll start with just a very brief few, Laura, actually, and also to speak to staff who are not able to be here, and then definitely invite my colleagues to fill in anything that they would like to share that may be a relevant update since the last, since the December meeting at least, when there was last the opportunity for updates. I will share just a few. Many of you are familiar with a program that we operate called the J1 Visa Waiver Program, or the Physician Waiver Program, whereby Oregon and every state has the opportunity to reserve 30 slots for physicians who are from other countries who have completed their residency in the United States to be able to stay and practice in the United States rather than return to their country of origin for 2 years as their visa requires them to do. I'm happy to report that we are ahead of where we typically are for this time of year. The program year begins in October, and we have so far filled 24 of Oregon's 30 allotted slots for this program, and that helps add to the capacity of our physician workforce that we would otherwise not have. There are definitely conversations happening in Congress, and legislation's been introduced about expanding the number of slots that states may be able to take advantage of. For example, many states don't use all 30 slots, and legislation would allow the unused slots to be reallocated among the states that do use their slots on a regular basis. So that's something to be looking for in the near future. Also, I'd share briefly, as many of you know, the supply and distribution of the workforce is something we're always tending to. And one of the key strategies for recruitment and retention of health professionals in those areas that experience, I'm so sorry, I'm turning off my ringer for another meeting that's going on. I realize that that's me and not somebody else. It has been financial incentives, and we have federal incentives that are important as well as our state incentives. So sorry, I'm going to go on do not disturb. I didn't do not disturb because I was afraid I get items from folks here in this meeting, so I'll just attend to that. In terms of federal incentives available, the National Health Service Corps is the largest source federally of health professional incentives. We're expecting that the federal government will open up the opportunity for health professionals in Oregon already serving to apply for federal loan repayment next month in February. We also know that the federal government will be announcing soon an opportunity specifically for health professionals providing maternal care. That would be certified nurse midwives, obstetricians, gynecologists, to be able to apply for a new separate set of funds if they are working in what's now called a maternal care target area, or a MICTA. Liza particularly has been doing work in identifying the MICTAs in the state of Oregon within the primary care health professional shortage areas, and seeing to the scores of those, because the scores typically, the higher the score, typically that's where HRSA starts in terms of making decisions around who to give a loan repayment award to. And then finally, to that end, we in the primary care office continue to be open to hearing from communities and health centers and clinics where they are working with a health professional shortage area score they feel does not adequately represent the degree of need in their community or for their clinic. And we do work diligently to get the best possible health professional data so that we can help provide an appropriate score. Sometimes it can be a lot of work that, to take a list of 100 health professionals that HRSA believes are providing care, and to go through that list and see, oh, well, these 4 have retired, these 15 have moved to other areas and are no longer providing care. It takes something. We do our best to identify with the data we have available who's working and who's not when we get a request, but we continue to be of the belief that the ones who know best who are actually providing care are the organizations that are providing the care. So we continue to work with organizations in partnership and attempt to get the very best and most advantageous profile of what is the actual healthcare workforce capacity that they're being judged on in determining the opportunity for federal awards. So open to any questions about that, particularly the last piece. If there aren't any, I would invite any of my colleagues in the PCO team, if you've got some relevant updates from, say, December, things that you'd like to showcase for the members of the Workforce Committee and guests, please feel free.
Mark, sorry to interrupt. Did you mention, and I might have missed this, did you mention something? Wasn't there some region or county that was having their HPSA score re-reviewed?
Let's see, there are a few that we've been working with, Laura, and I'm now going and taking myself back to pre-vacation mode. South Coos County is one of those areas, and we were able to secure a better or a higher HPSA score for Coos County. Part of where we sometimes get requests is where clinicians are looking to transfer from one area of the state to another area and then find that the threshold is not what the HPSA score is currently. So Curry County is one. Another, I know, Wheeler County, I think this goes back to November, December. Ashur Community Health Center, very small community health center, remote Frontier, Oregon, in looking to attract professionals. Their HPSA score was essentially negligible, and we reworked that area to combine that with, I believe, Gilliam County. So there's a new HPSA score that allows Ashur Community Health Center to successfully recruit using the National Health Service Corps resource as an inducement. And
okay.
You may know that we're doing some work with Whitebird Clinic also, and would love to follow up with you offline to see how we can really best help your clinic. Those are
okay,
Laura, that I had like right in mind.
Yeah, and I think I was working with John on this because we had when they're reviewing the HPSA scores, they review the providers in those areas, correct? And so I know I was working with John on this because we had some providers in Curry and Curry County that were listed on the report that were not currently providing services. And so information like that could definitely affect the HPSA score that a county has. So I think it's great if there's questions about those providers, maybe this committee could actually help with that, because I know, I saw that report and John and I were working on that there were providers that were not listed on that. So I think that's something that this committee could potentially help with, since we span different regions of the state.
Laura, that's great. I'll just say, maybe since we've got a little bit of time, our typical approach is, as I said again, we're clear that the ones who know best, who are the workers in the area, are those who are actually in the area, not us. Despite we've got robust data. We have federal database, we have our Medicaid claim database, our all payer, all claims database, the health workforce reporting program, and those are really great sources of data. And mostly there are the limitations in terms of time, how far back we're looking. And it's entirely possible, and usually does happen, that within a year people have retired or people have relocated, and we just can't keep up with that. So that is why we go to the local community to see what in this list is no longer accurate, and we try to make it as unburdened a process as possible. But we also know that particularly in urban areas, there are a lot of providers to be reviewing. With Asher, it was like you can look at like 3 providers, and that's pretty easy to do. And I think in many rural and frontier communities, it's the same way with dentistry, where you may have 6 dentists or 8 dentists, and it's pretty easy to see who's still practicing and who's not.
Yeah, and like I know Gordon put in the chat, we've had a lot of changes in Curry and Coos County as far as behavioral health systems and providers too. So thank you for that.
Yeah, great. Liza and I are happy to speak to any member or any community member offline about the process.
Gordon, if you could put your contact information in the chat, that'd be great. I know I talk to you frequently, but if you would stick it in there, that'd be awesome. Any other PCO updates from anyone? Not seeing any hands or hearing anything. And we are a little bit ahead of schedule. Mark, do we want to move on to the next item?
Sure.
Okay, so the next item is election of the chair and vice chair for 2023. Is that you, Mark, or is that me?
I'll go ahead and take a stab at this.
Okay.
Laura and Mark, just as an aside, I asked Jamie to pull up the section of the bylaws that talks about the terms and responsibilities. So Jamie, if you could put that.
Or this may be Paul to do.
Paul, you're muted again.
Yes. So Mark, you were gonna say.
Oh, I was going to say that at the January meeting is typically where the committee will elect a chair and vice chair. Going back to the bylaw change, what we've had in operation is that the chair has served a single 12-month term, but as the bylaws note, there's nothing in the bylaws that requires only a single term or limits an existing chair to serve a 12-month term. We did back in December invite members to either self-nominate or nominate another individual to serve either as chair or vice chair. We did get a nomination of Paul Gorman to serve as chair. I believe that there may be another nomination though that wants to be offered here today, as I understand it.
I'm not sure if there's more than one, but if Laura would be willing to serve as chair for another year, I would like to nominate her to do so.
Is that acceptable in the that's acceptable in the bylaws?
It is, there's nothing, I mean, this is my interpretation. There's nothing explicit in the bylaws that says that the chair is limited to a single 12-month term. It just says shall serve a 12-month term. So you have an annual election and the annual opportunity to select a chair and a vice chair. This was initially put in because a chair really did not want to serve for 2 years and made a very strong case for rotating leadership, but there's no restriction that I can see that a chair is limited to serving only for one 12-month term.
That's the way I was reading it, and it seems to me that the bylaws as written give the committee the flexibility to choose a chair, as long, you know, for whatever term they like.
Do I get a say?
I'll no, Laura, just kidding. Sorry. I wonder if I can throw in another bylaw like friendly amendment that we might consider locking down, and that would be actually limiting the numbers of successive 12-month terms for the chair, just to ensure that we've got some cultivation of leadership within the committee structure. I know many boards do that with a limit of 2 years, you know, and no more than. So that might be a thing for the committee to consider. Just an idea. And Laura, I would love the idea of you serving again, frankly.
Well, I mean, I would be honored to serve as another year's chair. I think, you know, we've talked about this before, and I think a lot of committees do have the 2-year term. Sometimes when you've done a year, you feel like you're just getting going with all the work, and then you are not chair anymore. So, I mean, like I said, I would be honored to serve another year's chair if the committee would vote me in, I guess.
Thanks.
But that means you stay as vice chair. We would elect you as vice chair again, Paul, and next year it's all you.
Yeah, this is Mark. You mentioned you thought there might be another nomination. Was it that one, or was there someone else that had a nomination to make?
Paul, it was a nomination of Laura, which I just discovered. An email chat might be a possibility a bit ago. So that was the second one I was referring to.
Yeah, this is Bhavesh. I would really second this, especially as Laura is doing such a great job and is also willing to participate for a second year. I think we have to really respect what she wishes to do, and I agree that the bylaws don't stipulate that a second term cannot be applied. So given that, I would definitely second Paul's nomination, and in fact, and I would also nominate Paul for vice chair to continue the second year.
Hi, I'm trying to understand, why is this an issue?
How do you mean?
So, what was the reason? So I think what I understand is that the reason why Laura would be vacating that role is because there was a stipulation that said you could only serve 1 year. And are we discovering that there is no such bylaws that says that?
Let me let Jamie bylaws back up. And to answer that, if we just look at the bylaws, I think it clarifies it, because the way the bylaws read now, it's a 12-month term.
Mm-hmm.
And so Laura was elected to a 12-month term, and according to the bylaws, she would stop being chair after 12 months, and it's up to the committee to elect a new chair. And what we looked at the bylaws for was to make sure there was nothing that said she couldn't be reelected and serve for another 12, and there isn't. So there's that flexibility. Does that clarify?
So are we wanting to change the bylaws so that it's 2 years and not 1 year, 12 months?
That I think is one of the options. It seems to me it's almost simpler to just reelect the person, and who knows what'll happen in who the next chair will be and what will be in the future. But that's why I mentioned, I think the bylaws as written now give the committee flexibility to choose its chair every year.
So this discussion is happening because we have just now started the new year versus ending of last term. Why did this discussion didn't happen at the end of last term? It's happening now because this is the first meeting of the new term. I guess I'm still not understanding, maybe as you flush this out, I'm still not understanding why this is an issue. Is it that,
yeah, that's,
what is the reason for why we feel that it should be 2 years versus 1 year? I'm hearing that, yeah, it takes a good year for you to really get your foot in and really get a grasp of what the role means. It makes sense for it to be 2 years. I hear that. So is that basically the reason why? Or is there that there's no one else that wants to step into that role?
I think you're asking a question about why the bylaws say what they say and whether they should be changed, which is different from the question of who's nominated to be elected. As the bylaws read at the moment, Laura's term is over, and the committee needs a new chair. And she can become and so it's up to the committee to choose a chair now. That's what the bylaws say now. So there is no 2-year term at the moment.
Okay,
Why we
you're not following me, and maybe I'm not explaining myself correctly. I'm trying to understand, why are we having this discussion now, right?
Because we have no chair now.
Okay, so then my assumption is correct, that this was not something that was decided at the end of the last term, even though we knew Laura would no longer be in that role. We did not have this discussion last term. It was basically assumed that Laura would end and there would be a new chair, which would be elected now, right, in January of 2023. And that is the reason why we're having this discussion today.
Dr. Hemmings,
that's what the bylaws say, exactly.
That's correct. And the bylaws were changed near the end of 2018. And at the time, the committee believed that having a 1 year on, 1 year on, 1 year off for the leadership made sense at the time. And it was assumed, although not stipulated in the bylaws, it was assumed that a chair would serve a single 1 year term and then become the immediate past chair. And near the end of 2022, we as staff were working with that assumption only. A nomination was brought of Paul to be in the position of chair, but in the conversation, we realized there's no limitation preventing Laura from serving another year as chair, and that's what's been now moved. And yes, January is when the election of a chair and vice chair would normally take place.
Okay. Yeah, just on other committees that I have served on, usually you have this discussion at the end of the term, which would have been last term. So this way you start out with knowing who the chair is. So that's why I was confused as to what happened. Did something happen where we don't have someone to step in the role of chair? I was just confused about why we were having this discussion now.
Thank you, Doctor. And I'm also seeing some comments in the chat with regard to 2 years versus 1 year. In our new discovery, the current language allows for a chair to either serve a year or serve 2 or more years by virtue of election for single year terms. I would propose that the committee leadership look between now and the next meeting at whether you want to propose any change to the existing language, which is flexible and permissive, and then bring that to the next meeting of this committee.
And let me just also add, it appears we are, at least in this only respect, like the House of Representatives, the new chair, the new speaker was elected after the end of the last term at the beginning of the new. More importantly, though, the way that the elections happen now, new members are part of the group electing the new chair. Whereas if that chair had been elected before, it would have been elected by the old members and the new members wouldn't have a say. So that's just one consideration. And as Mark said, it could be a matter to discuss afterwards. Anyway, that's why it is the way it is.
So Laura, I heard a motion and a second for the election of you as chair. I heard a motion for Paul as vice chair. I did not hear a second yet.
I didn't hear a motion.
Bhavesh made it.
Oh, that's right. Sorry.
So basically, so basically we're re-electing the same people. Was Paul in the role of vice chair before?
Mhm.
Oh, okay.
And just the last piece to add, in case it was not clear, back in November and December, near the end of last year, the reality that there would be an election in January was presented to the outgoing committee, and nominations were invited, and self-nominations were invited. And the only nominations which came forward to staff were Paul as chair and Bhavesh Rajani as a vice chair. But here we are in the meeting, and any nomination is permitted. So Laura, you could ask if there's a second to the nomination of Paul as vice chair. And then
I make a second. This is Manu. I'm sorry, did you hear me?
Yes,
Maybe
we
not.
did.
Okay, great, perfect, thank you.
Is it appropriate for me to call for a vote since I'm chair? Okay, perfect. So committee members, all those in favor of myself serving a second year as chair and Paul a second year of vice chair, raise your virtual real.
Could those be two separate motions?
Oh, yeah, sorry. I can do that, Dr. Hemmings. Yes. Okay. First motion, myself serving another year as chair. Raise your virtual hands, real hands, thumbs up. And I can't count, Mark, but I think we, okay.
yeah, you have
Any
11 members.
okay, any opposed? Virtual hands. Any abstaining? I don't see any. Okay, second second vote is for Paul as vice chair for a second term. All in favor, hands, virtual or otherwise? Okay, perfect. Thank you. Oh, I'm going to vote on that one. And any opposed? Any abstaining? Okay, motion carries for both. Okay, perfect. Thank you guys. I'm really excited to serve another term. And you know, just to your point, Dr. Hemmings, it sometimes feels like you just, like you said, you kind of just get in a groove and feel like you're doing all this great work and you want to continue, and then you're out, you know, your term is up. So I support the 2-year terms for the chair if we want to look at changing the bylaws, especially with the new work that we're going to be doing with the needs assessment. I'm really excited to work on that. So thank you. Thank you guys. I appreciate your confidence in me. And like I said, I'm very honored to serve another term. Okay. So moving on, I guess we're going to change our agenda, Paul, sorry. We are up to the discussion of the 2023 Healthcare Workforce Needs Assessment and Committee Priorities and Work for 2023. Let's see. Mark, do we have any visuals for that, or?
I think Paul's leading this, and Paul, you had asked if we could put up the matrix of 26 recommendations.
It's fine with me if Laura leads it, but I wanted to first comment. I just want to add, I looked at the charter for the committee to be sure this is okay. And the charter says recruit, train, and retain workforce. And I just want to suggest, as we think about priorities for the committee for the next year, that recruit, train, and retain are all part of the committee's recommendations, or part of our charter. And retain, the nursing workforce report mentioned that you can't fill a bucket if you got a hole in it. And meaning that we're losing nurses who are practicing at too high a rate to really increase the supply effectively. I think that's true across professions. And so as we think about how to increase the healthcare workforce, include what we can recommend be done to increase retention. And that especially brings up the question of burnout and resilience.
Which was one of our two key priorities that we wanted to call out to the Oregon Health Policy Board as well. Do we have any slides to put up, Mark, for this?
I'm gonna take my lead from Paul in terms of what you would like to put up as you tease up the discussion of taking the needs assessment and working through, and this could be a combination, Paul and Laura. Laura, you had also said that you really wanted to see the committee be able to dig in on some of these many recommendations. So, Paul, did you have a preference of how you'd like to start this off?
I don't. I guess I have a question for you in terms of, I don't remember what statutory or what we're definitely have to do by next year. There's certain things that have to be done, like the biennial report and so forth. Is there anything we need to know that's going to be part of our work over the next 12 months because it's required?
And what is legislatively required of us too? I'm not sure. We need to check that too.
Sure. Let me try. I think we're initiating now a conversation about the whole of the committee's work, and let me step back and I'll answer your question, but then also, if it works for you, Laura and Paul, I'll just provide a little context for why I think you want to have this on the agenda. To the direct question of legislatively, what is the committee required to do? There is the workforce needs assessment biennially. There is the evaluation of the effectiveness of health provider incentives. You've looked at both of those. There's a third component that's been part of your work that's not a specific legislative requirement, and that's the workforce diversity report that you'll be reviewing after the break today. Aside from that, the board obviously leans on the workforce committee to advise it on its statutory requirements for allocation from the healthcare provider incentive fund. So those pieces together, the reports and making recommendations to the board on the allocation of funds in the healthcare provider incentive fund are aspects that are specific and required. And then Paul, to your point, I think it's well said your statutory charge is a broad one. It's recruit, educate, and retain, and coordinating efforts around that. And then this agenda piece came from Laura, the work that you did around that letter. There are a host of recommendations in the healthcare workforce needs assessment. And I know one of the members of the board yesterday said, this is a lot of information. There is a lot of work. Do you have a sense of what is the most important work? And the folks at OSU who developed the assessment really kind of said, well, it's all important. We don't have anything particular. But I think, Laura and Paul, that was your point of having this committee be able to dig in and take 3 or 4 of what's 26 different recommendations and get those recommendations to the point where they're manageable, they're specific enough, you can actually implement something that will impact. So I think that's the context of this conversation is what does the committee want to take on of all of these recommendations from a large study saying, here are the needs for the workforce and what can be developed so it can be implemented either by OHA, the legislature, associations, healthcare employers, a combination thereof to really impact the workforce. How's that as a starter, Laura?
That sounds good. And Brenda, you can help me here if I remember one of the policy board members saying yesterday, and I don't remember who it was, but one of the health policy board members said, this was like you said, this is a lot of information. There are 30 recommendations in this report. It's a little overwhelming. And how do we realistically think that we can implement change with these 30 recommendations, which was an absolutely valid question. And so, Mark, I don't know if we have a chart that we can put up. I know you sent something, but Brenda, do you remember who was that mentioned that?
Yeah, less around who, and I think more around the intention of the message,
Yes.
Laura, just to reinforce what you're saying. I think, and this is true, we all work in really complex system and manage lots of project related things or large system change kinds of things. So we know how off track things like this can become. So I love the idea of gaining consensus with the OHPB about where this committee identifies its primary work and responsibility and really support that board in not getting trapped in we think we're doing progress because we picked on something that really isn't going to move the lever. Like it'll be important work to do, but perhaps not as impactful. And then the last thing I would say is, I noticed this in our own committee that when we think about workforce, sometimes we get discipline specific and we talk about this is what behavioral health needs, this is what primary care, this is where oral health is. And those dynamics, I think I'd love to have that unified voice on behalf of this committee and less discipline specific kind of interventions, if that's at least possible. And I don't know, I leave that to the wisdom of this group. Just a few nudges about how we might organize next steps.
And what I put up on the screen are, Paul, I think this is the sheet that you were asking about, the 26 specific identified recommendations from the report itself that was prepared by Oregon State University in the areas of, increasing the diversity of providers, improving the supply and distribution, enhancing the resiliency and well-being of the workforce, expanding training, career pathways, expanding the use of care delivery models, increasing use of community-based health care providers, and improving data collection.
Paul, you have your hand up.
I do. I just wanted to mention, sort of pertaining to what Brenda just said, I think a lot of the things, as we try to not be discipline specific, but work on things that affect all disciplines. And I asked about what we're required to do this year, because it's possible for a committee to kind of get lost in the details of the stuff that's required and not come up with new ideas and not do something that we really think is important. So I think this exercise in defining our own priorities is really a key. Dr. Hemmings had mentioned, how do we really influence anything? And I think it's kind of our chance to do what's important to us. I want to make a specific recommendation, though, or something that I think we should think about prioritizing, and that has to do with increasing the availability of training sites across professions and across the state. I think the shortage of clinical training sites is affecting all professions. It's especially affecting our ability to recruit and train people for rural and underserved areas, because those are the places that if you train people there, they're more likely to end up there. I mentioned before at previous meetings, OHSU actually reduced its class size from 160 to 140 because we have no place to train medical students. And I know this is a problem for nursing students and others as well. So one thing I'd like to see the committee do and somehow make recommendations to the policy board of the OHA and the legislature to come up with to use the levers the state has at its disposal to increase the number of places where people can be trained, especially training people in those areas where, I mean, not just geographic, but increasingly train people in places where they can practice afterwards, where we need them.
I'll just chime in on that front as far as we're a training site for dental students. And I think that it's all tied in with the workforce capacity, because the reason that we've said no to dental students in some recent years was that we didn't have the dental assistants to work with the students to support their training. And so I think it's this cyclical thing. So I completely agree, Paul, looking at the pipeline and how we're training workforce across all disciplines. And I think that stabilizing those potential training sites with their workforce and making sure that the folks there feel like they have the capacity and bandwidth to welcome in a student is a part of the picture as well.
That's a great point, because for those places that are smaller, have fewer resources, haven't traditionally trained health professionals, it's a big lift to find the staff and the resources and the time and how to fit students into your workflow and so forth. And so how do we support those places that might like to participate, but it's not easy to just start?
Exactly. Yep.
And Laura, could you remind us what we emphasized in our letter?
We emphasized increasing the diversity of the workforce and enhancing the resiliency, and I might have these words wrong, but increasing the resiliency and health and well-being of the workforce. If I remember correctly, that's what we did.
And for my part, I want to add just the burnout rates, the percentage of nurses who have one or more symptoms of burnout and the percentage of physicians that have one or more symptoms of burnout is astonishingly high. And if there's anything we could do if this committee could come up with, again, some kind of recommendations to the policy board and the OHA and the legislature, what can the state do to improve the well-being of the healthcare workforce? And I think we have to think beyond yoga training. Go to yoga class so you can stand your impossible job isn't going to be the solution. We have to think about how to make the job more possible, more rewarding, and less prone to inducing burnout.
Amen.
So those were the two that we had looked at, that we had recommended in the letter that we sent to the Oregon Health Policy Board. Again, that the report had 30 recommendations, and I think Mark said he sent it out. But we felt like, if we don't address these two areas of work, we don't, it's going to be hard to get the other areas done. And we said, for an example, we can't be effective in our quest to expand the career pathways for segments of the healthcare workforce if we do not have a healthy and resilient healthcare workforce to support Oregonians. And we can't be effective in finding a better distribution of the workforce throughout the state if healthcare workers are not able to stay in their professions due to burnout from non-inclusive practice environments. So, you know, I think I think from our perspective, those were the two that just kind of stood out for us. And I think we felt, and please, I welcome input, but I think if we felt like if we didn't potentially address those, then we couldn't really be successful in the other ones. So we want to take several of the recommendations in the report and hopefully develop plans, specific plans on how we can recommend those recommendations can be implemented, particularly in those two areas. And some of the strategies and that we might offer back to the Health Policy Board, as I said earlier, might include items like addressing the childcare as a barrier, or increasing compensation for some healthcare professionals to work in the areas with particular unmet need. Just as an example, we in Port Orford, there's never been a dentist. Some of you had heard me say this before. We worked for 9 months to get a dentist in Gold Beach. And I know there's some huge incentive going out for some of these providers, higher incentives than I've ever seen to get them into these areas of unmet need. But, you know, as far as us doing this work as a committee, there's 30 areas. How do we want to take those areas, see what we feel we want to work on and implement, and bring that back to the Health Policy Board? But like I said, it's almost overwhelming when you look at that report. I had to take it in sections and look at it because there were it's just so much information. But the matrix that Mark sent out that he was, you know, he's showing or did show on our Zoom call, it kind of breaks it down as areas of potential importance and how we want to address it. And I'm not sure who had their hand up first, but go ahead. Go ahead, Elena.
No, I think it was Bhavesh. You go ahead, Bhavesh.
Oh, Bhavesh, I'm sorry.
Oh, thank you. I'm sorry, my camera is not on because it's broken and I'm waiting for a new one to arrive to plug in. So I apologize. I think the underlying theme in both these areas is a lack of workforce overall. And the burden that is felt by providers still in the system who have not at this point collapsed and, you know, and felt overwhelmed from the burnout that's going on is worsened by the fact that there aren't enough staff to support, you know, taking on the workload. And that's in all areas. I'm talking about providers in general, but I'm talking about nursing staff, I'm talking about MAs, I'm talking about every possible part of our healthcare system. And in general, we have lost during the pandemic a significant amount of staffing that has affected the burden that people are feeling. So things are worse because of that. And I agree that, you know, we increase the diversity of the workforce and so on, but the underlying theme is a lack of adequate staff. And one of the best ways we can help reduce the strain people are feeling is to have integrated support with different types of staff available. Yeah, you know, behavioral health, you know, an example, integrating behavioral health into a clinic can immensely reduce the burden on the primary care provider. And there are still lots of clinics who don't have behavioral health clinicians associated with them. And you know, there needs to be more emphasis on creating an integrated culture to develop primary care homes that are supported not just by physicians, by multiple different skill sets that will help the patients better. And I think that that's really the underlying thing that we need to emphasize the continued need for recruitment in all our different arenas, and to emphasize that integrated approach to our healthcare.
Well, I feel like a really great bridge between the two comments, because that resonates a lot, Bhavesh, on a personal level. As a provider, I'm a dentist, and we have some integrated behavioral health in our dental clinic, and also have some open streams of communication with medical providers. Although we don't have any medical providers in our building, we do within our system. And those are the days where I feel the most satisfied and engaged and excited about my job, is when we're working as a team to care for a patient, and I feel really connected to that team. So a big exclamation point on that comment, and also feeling when I hear of a staff, my most burnout heavy days are when I hear of staff transitions and tell a story about, what will the downstream impact be on me as a provider. So yeah, every time we hear of someone moving on, that for personally adds to my burnout. My question initially was to you, Brenda, so I like that your hand is raised. These are a lot of priorities that we've shared with the policy board. Where in your role on that, or as the priorities were presented, were there any areas where there was a lot of momentum or excitement where we could really capitalize on that momentum and kind of build on that? Did it seem pretty neutral? Like, what was the response to this matrix and our report to the policy board?
Yeah, the board did not review this level of detail. We had in our documents the full report from OSU. We didn't have direction necessarily to review priority, because I think the expectation is that this committee does that work first, and then bring your best thinking forward for the board's reaction. And so the reason I raised my hand was both to share that, and I think also just to go back to something, Laura, you had said about what we prepare for the board. I just urge a bit of caution that whatever we're communicating, how would I say that? Like, it's really easy to pick off very specific efforts or initiatives. I'll use childcare as an example. I think you voiced critical importance in some communities, and in other communities, that's not necessarily perhaps a statewide perspective, right? So whatever we end up bringing forward to the full board, I much like my earlier comment about, multiple professions and disciplines and kind of this broad arching body of work, but I think also it doesn't preclude our committee to take on specific efforts or initiatives that don't necessarily have full board, say so, right? So say there's a place for childcare, but that's not going to reach a specific kind of a threshold that we're saying we really need this kind of policy consideration for the agency to address or for the board to address. So that's just as we think about it, kind of framing both the future reactivity or response or engagement level of the board, Elena. And then I think just back to Laura and the way we organize, which one of these many important initiatives do we really want to highlight and call attention to? Thanks.
Thanks, Brenda. Ian, I see your hand is up.
Yes, so I really appreciate the idea of having behavioral health as a part of the burnout prevention within clinics. One of the things I hear consistently from providers is social determinants of health, and how we can integrate social determinants of health services within primary care. And I think that as well has a potential for some real impact in the conversation that we're having. Second area, second area is, one of the things I've seen is data, and the data model that we're working off of seems to change over time, and it's inconsistent at the moment, or at least we're waiting on things. And the more that we can figure out what our data model is and look into the future at where we're predicting, the more power we might have to move those numbers, move those, more importantly, move the quality of service and the quantity of service to those people. And so, not only looking at data about our clients or our patients, but data about our providers and our staff, and coming up with something that is more comprehensive. Thank you.
No, thanks, Ian. I appreciate that. I don't see, are there any more hands up? I don't see them. So Jamie, would it be possible to put the matrix back up for just a moment?
I think I had that, Laura.
Or Mark?
Yeah, I'm gonna put up just.
I think, you know, when Paul and Mark and I were chatting about this earlier, we were wondering if it would be feasible to look at the list and maybe pick the top 4 that resonate with us that we might like to see the committee develop. Maybe looking at the ideas of diversity and resiliency. We could have a little bit of discussion about it now. I did ask Mark if we could, we've been having our off meetings. So our regular healthcare workforce committee meeting will be in March again. I would like to keep our off meetings in the off months. I would like to see if we could have a meeting in February where we could maybe come to consensus about the 4 areas that we would like to work in, and then maybe have some time in our March meeting to further that discussion. So, if everyone would be in agreement with that, we could take a look at this, see which 4 we think we might want to work on as a committee. We don't have to decide those today by any means. We could think about it until February and then discuss it further. Paul, I know you, and I didn't see who had your hand up first. I'm sorry, you guys.
Go ahead, Paul.
Elena was first.
Okay, I was just gonna say, I know in past committee experiences outside of here, when there's been a large bolus of information to digest like this, sometimes coming into a meeting, having done like a preliminary survey, sort of have a temperature read on where we're at. Is there an overwhelming priority or overwhelming preference for 4 of these? Are we kind of split across all 30? I don't know what the rules are of doing a survey outside of the recorded meeting times, but if that was a possibility, it might be something to consider to kind of get a read on where we're at and help that guide the conversation.
Kind of like a Survey Monkey type.
Exactly. Yeah, like rate your top 4, and then we can see where the committee lies.
Right. That's a great idea. Paul.
Well, I think that's a great idea, that pre-meeting survey to get priorities identified. And I like Laura's idea of meeting in the intervening months. One of the things that I think helped that be successful last year was they were very focused meetings. The extra meetings weren't the general meeting of all the kinds of things the committee talks about, but there was something we were working on and we focused on that. It was a shorter meeting and it was kind of easier to get something done. So I support the idea of having a February meeting that's focused on this, for example, this priority question. And then our March meeting would be the usual with the bigger agenda.
Yeah, and I think, we did agree to do that for last year when I was chair, because I really pushed for that and asked the staff to help us with that. And I think we need to make sure that with Mark and the staff that would be okay with them to staff those off meetings, because I don't think we agreed to do it past that. But I think it just helps us, like we did last year. We focused on one specific, maybe 2 specific topics that we did not have time for appropriate discussion in the regular meeting months. And I think this is a great idea where we could potentially send out the Survey Monkey prior to the February meeting and then come back in February and spend some time discussing it, if that would be acceptable, and the OHA staff would be willing to staff that.
Laura, I'll speak for us at OHA. I think we can entertain the February meeting. I definitely agree with Paul that one of the success factors is limiting those off-month meetings to a very focused, specific topic, maybe 1.5 topics, but really best. If you want to do a meeting on February the 8th, at 9 a.m. Do you think an hour would be sufficient? I know the special meetings were generally 90 minutes, but do you think an hour would be sufficient for discussion? Would you rather do 90 minutes? And we could say yes on February 8th, which is like the first Wednesday after the first Tuesday.
I mean, I know a lot of times we have 90 minutes and people drop off after an hour. I would support 90 meetings if we can do that. I think this past year when we did those meetings, pretty much everybody stayed on for the 90 minutes. And I think for this discussion, 90 minutes would be good because I think we're gonna have 4 topics to discuss and go through. So, you know, if the committee members would be in favor of that, I would say 90, since that's what we did before.
And then we can talk further with the leadership about whether an off-month meeting is an ongoing part of the structure or just as needed. We might use those off-month meetings for like subcommittee work as you decide what are the initiatives that you want to carry forward to operationalize.
Any quick discussion from committee members? Would you be in favor of keeping the structure we had last year? Yeah, I think it worked really well. Okay. Mark, go ahead.
Well, I'm just going to add, I think that idea works great if we have a focus.
Yes.
Meaning a lot goes into the meetings are more successful if, you know, we're meeting for a reason, we know what we're up to, we're going to get it done, and there's the reason to schedule extra meetings if there isn't that sort of,
correct.
We know what we're doing.
And I think last year we pretty much had something every month that we needed to focus on, so that worked really well. Mark, do you know, is a Survey Monkey acceptable, appropriate? Could we do that? Because
we can sort out a Survey Monkey for.
Okay.
You bet. And
I think that would help us.
Right. And Paul and Laura, I was thinking, and we can certainly talk more about this, I was thinking of holding that every other monthly space for work that members of the committee in work groups or subcommittees could do around these individual initiatives.
Yep, I think that's great. Okay, thank you all for the discussion and willingness to meet in the interim months. I appreciate that. We are right on time. It's 11 o'clock. We are due for a break now for 10 minutes. Feel free to turn off your cameras while we break, and we will see everyone back at 11:10. Hi, everyone. It is 11:10, so everyone should be making their way back. And committee members, if you're able to turn your camera on or give me a thumbs up that you're back. I know some folks can't have their camera on. That would be great before we get started. I love that new thumbs up. It does this thing now when you do some of them. Zoom is ever changing. Let's see. So Mark, next on the agenda, we have the review, discussion, and approval of the workforce diversity report. Were we planning on doing a formal approval on that report today?
We are anticipating a vote on this. Yes.
Okay.
This item is being brought to the Oregon Health Policy Board next month.
Next month. That's what I thought. I wanted just to double check on that because we have some time. And I was not clear on who was going to start leading that discussion because it says
I think for Piper and Andy.
Piper. Okay. It just says the team, and I know there's a group of you that have worked really hard on this. So, okay, we will go ahead and get started. And Piper, I will let you kick it off.
Great. So the reason I think why it says team also is that we all are going to kind of help with this presentation. Sarah or Meredith, would one of you mind sharing the presentation? Oh, or
we got Jamie.
It's like Jamie. Okay, great. So I'm just here to introduce. So I'm Piper Block. I'm the research and data manager in the Office of Health Analytics. Really, I just started. So the bulk of this work has been done by the other folks who are listed here: Derek Reinke, Sarah Grusing, Meredith Halling, and Andy Davis. They've done an excellent job. And the only other thing I want to say about this, so this is the diversity report. We are hoping to get an official vote today so we can bring it to the Oregon Health Policy Board next month. And this is a draft. There are a few things that we still need to update, and we will kind of acknowledge each of those things during the presentation, and I will also wrap up with that at the end as well. So with that, I'm going to hand it over to Sarah to give us a little overview about the Healthcare Workforce Reporting Program before we jump into the diversity report itself.
Thanks, Piper. Next slide, please. Hi, I'm Sarah Grusing, one of the data analysts on the Healthcare Workforce Reporting Program team, and I'll give a very quick overview of our program, just as a reminder, since everyone here has probably heard this before. OHA's Healthcare Workforce Reporting Program was created in 2009 with the passage of House Bill 2009, which required OHA to collaborate with 7 health profession licensing boards to collect healthcare workforce data during their license renewal processes. During the 2015 Oregon legislative session, Senate Bill 230 added 10 more health licensing boards to this data collection program, bringing the number of boards up to 17. We're lucky to have this program here in Oregon to be able to measure our progress with our workforce goals because most states don't have these data. That being said, there are some known limitations to our data. It's self-reported by the licensees themselves, and we do sometimes have anecdotal observations that our data doesn't completely reflect what people are seeing out in the real world. Next slide, please. This slide shows the list of the boards that require their members to take the survey when they renew their licenses, either every year or every 2 years. First-time licensees don't have to take the survey, so we have some known lag for that reason. Renewal cycles differ between boards, and older data is pulled forward to make the most complete data set each reporting cycle. Our data set also does not represent the entire healthcare workforce. Many unlicensed or certified healthcare professionals working in Oregon are not represented, such as traditional health workers, qualified mental health professionals, medical assistants, etc. Next slide, please. The Healthcare Workforce Reporting Program has some required reports and deliverables listed here. Back in November, we came and talked to this group about the Workforce Supply Report. Today's presentation and discussion will be on the draft diversity report listed second on this slide. Now I'll hand the presentation over to Andy and Meredith to talk more about this year's workforce diversity report.
Thanks, Sarah. Could we go to the next slide? So I'll go over some basics on our methodology, starting first with our data collection process. As Sarah kind of described, survey data is collected online when licensees renew their license. So first-time licensees don't have to take the survey, and we don't have data on that piece of the workforce population. At the time of license renewal, licensees complete the healthcare workforce survey, which is how we collect information on these things listed here. So provider demographics, education information, practice information, which includes things like the location, practice setting, if patients use Medicaid or Oregon Health Plan, telehealth questions, total hours at each location. We collect information on future plans. So we ask if over the next 2 years, if providers intend to keep working at their current location, move to a different location in Oregon, move out of the state, or leave the field altogether. And then we also ask if over the next 2 years, if they have planned to maintain practice hours, reduce or increase. And then finally, we collect information on specialties, on specialty fields. And this information is used to create specialty groups for analysis, including primary care, behavioral health, and oral health providers. Because the survey is completed at the time of license renewal, the timing and frequency of survey collection varies by board. So boards renew licenses every 1 or 2 years, and then they also have different renewal periods during the year. So for example, nurses renew every 2 years on their birthday, while physicians renew every 2 years in Q4, October to December of odd years. So annual data sets for our program include all providers that are licensed by each board in January of each year. And this kind of nuance in differing renewal cycles and periods becomes important as we look at the implementation of REAL-D data collection, and then the analysis of that data. So let's go to the next slide and we can dive into that a little more. Thank you. As this is our workforce diversity report, it focuses primarily on race, ethnicity, language, and disability, or REAL-D demographic data. Collecting REAL-D is an effort to increase and standardize data collection across the Oregon Department of Human Services and the OHA. And it involves a set of standardized data categories and questions. Because REAL-D data only exists for the healthcare workforce for the most recent data collection cycle, it's not possible to compare the data directly to that of previous cycles. So previously, race and ethnicity categories in the workforce data were coded to match broad ACS categories. ACS stands for the American Community Survey. A survey is conducted by the Census Bureau. And those categories can be seen on the left side of this table. While implementing REAL-D involves collecting data at a more detailed, granular level, shown in the list on the right, asked if they speak languages other than English. If the response is yes, then they can select up to 2 languages that they speak other than English. Respondents are also provided, they provide their proficiency level, and then if they use the language when they are providing patient care at work. And then finally, disability. Disability was not collected in any form pre-REAL-D, but with REAL-D implementation, survey respondents are now asked if they experience different functional difficulties, including difficulty seeing, hearing, physical difficulties, such as walking or climbing stairs, and then cognitive tasks, such as concentrating, remembering, or making decisions. Respondents who indicate yes to these are then asked what age the condition began. Could we go to the next slide? Yes, so I wanted to talk more about the REAL-D race and ethnicity data collection to address this exact question. So this is the format for the data collection. People complete the survey online and they see 1 question at a time. So first, the survey respondents are asked an open response question about how they identify their race, ethnicity, tribal affiliation, country of origin, or ancestry. So this is just an open text identification, and we're collecting it in our survey, but we did not process it for use in this report. So what we do use is this next section where respondents can select all categories that apply from this list. So if a single category is selected, then the respondent is assigned to that race and ethnicity category for data analysis. If more than one category is selected, respondents then are asked a follow-up question to indicate if they think of one category as their primary race or ethnicity identity, and then that primary category is used for analysis. If multiple categories are selected, but no primary racial or ethnic identity is indicated, the race and ethnicity category is assigned for analysis using the rarest group first methodology, which is recommended to us by our OHA Office of Equity and Inclusion. So for example, if a person selected both Alaskan Native and Western European, and then did not indicate one as their primary identity, they would be counted as Alaskan Native for our analysis, as that is a rare group in Oregon. So this also means that in contrast to previous reports, in this report, there is no multiracial category. Could we go to the next slide? So the availability of REAL-D data for any given board depends on their license renewal cycle. So the transition to REAL-D collection and reporting is not complete for the data collection cycle that we are working with for this report. So this report's collection period spans January 2020 to January 2022. And the Healthcare Workforce Reporting Program fully implemented REAL-D standards in January of 2021. Fortunately, many licensing boards collect data annually, so they have REAL-D data based on collection from January 21 to January 22. However, for licensed occupations that only renew every other year on even numbered years, we will not have REAL-D data until the 2022 to 2024 report. And the groups that fall in that category, consult my list, are acupuncturists, occupational therapists, and pharmacy technicians. And then there's also another set of occupations that renew over a 2-year period, but with about half of the licensees renew every year. And those folks are dentists, dental hygienists, social workers, psychologists, massage therapists, radiographers, and nurses. However, overall, for this report, over 60.5% of the workforce reporting program data is REAL-D compliant. So that means that for some analyses, we can only report aggregate level parent data, and for others, we can report REAL-D subgroup data in part or in whole, depending on occupation. And then finally, for state population level estimates, we use data provided by, again, our Office of Equity and Inclusion that imputes the REAL-D race and ethnicity category values from the ACS data sets. So the AC data sets also include things like language, ancestry, and place of birth. And those are used to impute statewide population estimates that can be compared to the REAL-D data values for both the parent and the subgroup level data. So with that, I will hand it over to Andy to talk about our findings.
Thank you, Meredith. So next slide, please, Jamie. So one of the things we wanted to come to you today, in addition to sort of asking for approval for us to move the report on, is just to talk through some of the figures and tables that we've got in the report to hopefully help understanding of what's going on in these figures. What I wanted to start with really, and I'm going to cover the sections on race, ethnicity, and gender in this segment anyway. And one of the things I wanted to start with is this is showing the trend line of the way race and ethnicity categories have been reported in Oregon, been reported in our previous diversity report, and how it has sort of changed a bit with the REAL-D implementation. I think what I really want to emphasize here is that we're seeing some changes that you can see on the right end of this graph between this current report and the previous iteration that I think it's important to characterize as changes in the way we're measuring and reporting, and not necessarily changes in the underlying population of Oregon. You know, there's not there's not a compelling reason for us to believe that the underlying population in Oregon has changed as dramatically as we might see in this graph or that's contained in the report. But what we're seeing is a change in how we've asked questions and how we're reporting these categories. So I think the big change to catch here, and Meredith discussed this, is that folks that have previously reported as multi-race or multiracial are now being recategorized into what we would call the rarest race category, so that you can see on this figure that the multi-race category has dropped essentially to 0 here, and other categories mostly have had an uptick. The exception would be the Latino, Latinx segment of this population. And I'll point out that is also a change in the questions asked. So Real D and this imputation is, as Meredith said, looking at things like language use, country of origin, ancestry, and reported demographic. Whereas ACS data, the American Community Survey, asks a specific question about ethnicity, whether you consider yourself Hispanic, Latino. So that is also a change in the, not necessarily the composition of Oregon, but just the way this is reported. So we just want to sort of set that expectation that we've got some changes here that are part of the way we're reporting and recording things that aren't necessarily a big change in the population itself. Jamie, could we go to the next slide here? So we've reported in a similar way to this before. This graph is showing a baseline data for Oregon. That's the sort of peach orange shade in the back, compared to the healthcare worker population that we've surveyed. This is at the parent level, so this actually shows both the 60% of people who have Real D data and the 40% of people that we still have in the older system. So this is a sort of most complete version of the population that we can show. But what we see here across the spectrum of healthcare occupations is basically we've got some overrepresentation in Asian and white persons who have answered our survey. We have underrepresentation in most other groups. We have more dramatic overrepresentation in terms of raw quantity in Latino, Latinx population, as well as American Indian population. But Black and African American and Native Hawaiian, Pacific Islander are also underrepresented. So again, this is comparing the baseline Oregon population to what we're seeing in the healthcare workforce. And this is what we would call the parent level, parent category. Jamie, could you go to the next slide? So this is what we would call subgroup or maybe granular population. So when we're moving down to that 60% of the folks who have answered a question about what they consider their subgroup population, this is this table, and it's truncated here just to fit it on the slide, but it goes all the way down through the categories in the report itself. But we're using the same format. I realize there's an extra percentage in the parenthetical there, but we're using the same format. The orange population is the Oregon population, and that's reported to us by OEI, the Office of Equity and Inclusion, compared to what we're seeing in the healthcare workforce. One thing I do want to, yes, so I just got a message, sidebar. So I've been saying healthcare workforce. I'm saying that broadly, colloquially. It is important to note this is just the licensed healthcare workforce. So we work with those 17 licensing boards. This survey data does not include, we've done some projects on, say, certified healthcare workers. This does not include those folks. This is just the 17 licensed boards. So if I say healthcare workers, I'm meaning licensed healthcare professionals in the state of Oregon. Okay, so I wanted to point out with this graph in particular, the data that we originally started working with, and we've recently, like this week, gotten an update on this data from OEI, shows that other white in this category at a 0. That was that was a quirk of how they were categorizing things when OEI started imputing this data based on where people were from, what language they spoke, etc. We worked a bit with OEI, and they issued a revision on Monday, which has not made it into the draft report. But I think one of the things that we're sort of asking you all to do is approve this, because we have a biennial timeline for this that's in January. So we're asking for approval so that we can sort of move on to the next steps of our process with this report. But we know that some things will change. I wanted to point out specifically, I know that other white number, the baseline for Oregon, is going to be reported at 22%, based on the new numbers from OEI, and all of that comes out of the Western European category. So Western European will come down, and other white will go up to 22. Oh, and I just want to mention, I'm getting a handful of things in chat that are directed at me. That's totally fair to do that. I would say, and I can try to address things, especially in the QA, but if you can send messages to everyone, it makes it easier for us to save the chat afterward, so that if it's something that I need to follow up on, we have a better record. So just showing the subgroups here. Again, we're trying to present the granular data as much as possible, but we do only have it for specific professions and licensing boards. So sometimes we make the choice to go to parent level data, but we're trying to show the whole population here as much as we can. Okay, so Paul's asking about confidence intervals and how we're doing this. So I think one of the things that that's important to note about our survey, we have in this particular iteration of the survey, we have this segment of the population who has not submitted RealD data yet. But actually our survey, most of the time when we present it, we're presenting full sample data. So we have surveyed literally everyone who's renewed their license. So we typically don't report confidence intervals or anything of that nature. I think maybe we could have made a choice to try and estimate based on the RealD data that we have, but the choice we made was to present exactly the data that we have in our database of 100% sampled.
Got it. Thank you.
Sure. Thanks, Paul.
I
Yeah.
had my hand up for a while. Could I ask a question? Is that okay?
Sure, and I apologize, Dr. Hemmings, I didn't see your hand up in the corner there.
Okay, so my question is, this is healthcare workers with an active license, right? But that does not equate to the actual number of healthcare workers who are actually providing care.
That's accurate. So our sample actually includes folks that have retired, folks that are unemployed, folks that are underemployed. All of them would be included. Yeah.
Does your survey actually separate all of those categories out?
Yeah, so we do have a question in the survey that asks them what their current employment is, in terms of, and they can report the categories that I just listed. We also ask them how many hours they work in an average week, so that we can get a sense of, as I said, sort of the threshold of underemployment, maybe how many people are working part-time, things like that.
Do you have that data?
We do, and actually, so I think one of the things that's useful for us as a group is, you know, in this case, if that's of interest to the committee to see that sort of feedback, or to see breakdowns on employment characterization by race and ethnicity category or something like that, I think that's great feedback for us to include either in a later draft of this report or in future iterations.
Yeah, I think that's important because I can speak for the behavioral health workforce in terms of, you know, the population needs where it doesn't reflect the population demographics, the population which you see here, overall, but I think it's important to be able to identify the availability and access, right, to actual healthcare workers in the actual workforce, more so than those that are just licensed.
Absolutely. That makes perfect sense to me. I think that's a valuable thing for us to look at. I will note Derek Franke, who was our interim manager, did note we have some breakdowns of that sort of data in the supply report, which we brought to the committee previously. It is not broken down by these categories that are in the diversity report. So, you know, if the combination of those two things is useful, absolutely, we can move forward with that.
It's also broken down per profession, correct?
Yes, so at least for the professions that we have real D data for, we can certainly do that. As Meredith noted, we don't have it for everyone, but we will in the future. Jamie, let me move on to the next slide, and I might ask Dr. Hemmings, totally great to take your question there. I might ask for, just to make sure we get through the material and give question time at the end, that we do have a Q&A section in the agenda as well. So we might hold questions for a little bit. So this table, so Mark asked me yesterday about elements of this report that might lead to action or direct action from this committee. I think this table, which is a holdover from previous reports that we've updated for this cycle, is a good one for directing action and for maybe pointing to the committee to areas that you might want to look at. So this table is a heat map of both gender and race categories across different professions. Folks that are overrepresented in a category are in blue. Folks that are underrepresented are in orange. Underrepresentation or overrepresentation is a threshold of 2% plus minus. So it's not a huge variation, but some of these categories, there's relatively small populations you're working with. So 2% for a population that only has 3% representation in all of Oregon, like the Black African American population, that's a big segment, right? But I think the things that I would take away from this heat map, and they're noted in the report, are things like, if you look at the Latino, Latinx column here, there are a couple of standout overrepresentation portions, chiropractic assistants and certified nursing assistants. There are a lot of underrepresented categories or professions for that population. There is a correlation seemingly between the education level, the threshold to enter professions, and the representation within that category. So high education professions are having less people in that category than lower education, smaller threshold professions. The reverse is true in the white category. So doctors, dentists are highly represented in white and Asian populations and have low representation in other people of color categories. So I think that one of the things that we would take away from a chart like this is that there's some correlation that might deserve examination and action around education and thresholds for entering a profession and race and ethnicity category. Just to see thumbs up or down, does that make sense as a way to look at this chart and a way to think about this particular piece of data? Okay, I'm seeing at least a couple nods. Okay. Jamie, let's go to the next slide. So this, I know, is a challenge. These are small numbers and a busy chart, right? I wanted to present and talk about this one for a minute because, as we noted, it's really difficult, if not impossible, to create like trending data because we've got a new category system under Real D for race and ethnicity, right? So we have as I showed in the first slide that I discussed, we've got some changes that just happened because we've got new categories and new questions. So we don't want to compare to an old trend line and say, oh, there's been this change, because it might just be due to the questions we're asking and the way we're categorizing people. But we wanted to offer some ways to look at the data that we've collected for this cycle and make some conclusions about where this workforce is heading, right? And so this is a thing that that we came up with in terms of presenting age structure. So this is looking at the cohorts within the workforce of like 10-year age brackets. And when we look at the cohorts, you can see it, and let's say on the left-hand side of this graphic, the thicker ends of the cohort for the Latino and the Native Hawaiian Pacific Islander segment are in the younger part of the cohort, meaning that we've got more young professionals either in the under 30 or the 30 to 39 cohorts that are in those professions compared to their race, ethnicity group as a whole. On the other hand, you've got in like the white category, especially, the thicker parts of their cohort comparatively are in the older segments of the population. So folks, over 50 in the white cohort are more common. I included this graphic on the right, which is very draft. It's not even in the draft that you were sent on Monday, because I literally made it this morning. But I think what I want to take away from this is if you look at the representation over time in each cohort, so the white category at the bottom, you can see basically they're 92% of the 70 and older population of healthcare workers. They're 89% of the 60 to 69 cohort, right? But when we look at the youngest cohorts under 30 to 39, the baseline population for Oregon of white individuals in our population is 75%. So that 30 to 39 is very close to the baseline population. The under 30 is actually under the baseline population. So there's some transition happening in the people coming into the workforce. The under 39 category for, say, the Latino population, that's really close to the state average of 12.3%. So I think a takeaway from us or from this report data might be that the efforts you're talking about in employee retention, things like that, you've got a relatively equitable population in the younger cohorts compared to the older cohorts. So finding ways to focus retention efforts on these new populations that are coming into the workforce, culturally specific retention efforts might be something that comes out of this, that you need to retain those populations as they are looking right here in the younger cohort. I will add a caveat that in combination with what I was talking about on the heat map with education, barriers to entry and things like that, the under 30 cohort may be showing overrepresentation because those are folks coming into the workforce at a young age that don't need as much education as some other cohorts. So that would just be something to be aware of and cautious about too. Okay, Jamie, could we go next slide? And I'm going to hand this one back over to Meredith.
Great, thanks, Andy. So this slide on this chart, we have the results from our language section. So this chart is showing the top languages spoken by the licensed workforce, and that's the bars in orange. And then they're overlaid on the percent of the Oregon population that speaks that language, which is gray. One thing to note about this is that the ACS data that is used for the Oregon population, the question on that form is worded, do you speak a language other than English at home? And then if yes, they're asked, what is that language? Well, our workforce survey asks a slightly different question. It asks, do you speak languages other than English? And then it asks which languages are spoken. And then if they use that language at work, providing care to patients. So there are slight differences in the wordings of those questions. But as we can see here, Spanish is the most frequently reported non-English language spoken by the licensed workforce, with nearly 10% reporting that they speak that language. However, only about half of them speak Spanish at an advanced or at a native level. For the other top reported languages, the advanced or native speakers are more closely, they more closely match the underlying Oregon population. Another interesting piece of this is the follow-up question, which asked if the providers use this language at work with clients, with patients. So a really high percent, 80.4% of Spanish speakers reported using that language with clients. While the percentages with the other top languages are much lower when asked if they use those languages at work. Could we go to the next slide? It's another important piece when looking at language is healthcare interpreters. So certified and qualified interpreters, they have formal training and experience to be certified, and they have to pass a national certification exam. The Healthcare Workforce Reporting Program, as Andy mentioned earlier, we do not currently collect data on this group. But in 2021, a survey of healthcare interpreters was done as a collaboration between our program and OHA's Healthcare Interpreter Program. So it's a pilot study, a relatively small sample size. So results do need to be interpreted carefully, but can definitely inform future studies. The survey was sent out to 703 qualified or certified healthcare interpreters in the state. 149 responded. So that's our sample here. The study results found that Spanish was the most commonly reported language that interpreters were qualified or certified in. So 90 of the 149 reported being Spanish interpreters. And the next most common were American Sign Language, Vietnamese, and Arabic. But those total numbers are much lower. In the chart on the upper right-hand corner, this is showing, let's see. Oh yeah, this is showing the setting that interpreters work in. So we can see that the majority of interpreters are working in a clinic or a hospital setting. And then in the map on the bottom right-hand corner is showing where the clients or patients served by the interpreters are located. So you can see that the clients served by interpreters are pretty concentrated in the Tri-Counties metro area. I think we've got 57% of survey respondents report that the clients they serve clients in Multnomah County, and then a lot of zeros in the southeastern part of the state. As a final note, there is an online publicly available dashboard that provides a lot more information about the findings of this study, if you're interested in that. And so I will hand things back over to Andy.
Thank you, Meredith. I will just note that dashboard, as Meredith said, is publicly available. That this data presentation is not part of the diversity report as presented, just because we've already got that dashboard in publicly available mode. Paul, I see a hand up from you. Is it possible for us to hold the question until toward the end, or?
Yeah.
Okay, thank you. So Jamie, could we go next slide? So this data, this is the disability graph. Again, I've cut off the bottom just to fit it on this slide and have it still reasonably legible. But there is one more question category at the bottom of this within the diversity report itself. Basically, I just wanted to talk through, we have a 6-question battery of questions about disability that we've added this year. This is part of, or excuse me, we added in 2021, it's added in this year's report. That is part of the REAL-D analysis package. So all of the boards, with the exception of the Oregon Medical Board, have allowed us to ask these questions about disability. So this is not full sample as far as all of our professions, but it is full sample within those boards that have asked it. And so we're able to report some now, and we've broken down based on category of specialty care area. So we've got the 3 main specialty groups, as well as just folks that do not fall into one of those specialty areas represented in this graph. I think the takeaway largely for this section is that disability is less prevalent in the healthcare workforce occupations than it is in the population overall in Oregon. That is true across all occupations, and that within the healthcare worker occupations, that behavioral health has the highest incident of most of the questions that we've asked. We also have pretty small sample sizes here. And I think in addition to what we're saying about the not all licensed occupations having gone through the REAL-D data at this point, you know, we might just take some caution about how we treat these numbers before we've got the full array of professions having gone through this series of questions. But I think it's interesting data for us. You know, I think that this is just an area of study that we haven't had the chance to look at really at all before this cycle. So, you know, I think this is an area where you all can give us useful feedback about what more you would like to know in this section, so that we can try to build it out in a way that's helpful for the board, or for the committee and for the health policy board later in the future. Jamie, could we go to the next one? Okay, and I think I will turn this over to Piper at this point.
Great. So I just want to congratulate this team for doing such great work. Like I said, I just kind of jumped in at the end, but I think this is really exciting. I just want to give a little context very quickly about the REAL-D guidelines. That the reason these exist, or one of the many reasons these exist, is that the previous type of race and ethnicity data that we had was very macro. It was like white, Black, Hispanic, Latino, Asian, other, like kind of in these big buckets that don't really have any very much meaning in terms of communities. And so the REAL-D data can be and will be a really powerful tool for making sure to give different communities voice and visibility when we have things like the diversity report. And as we're moving from this old system to a new one, there are just a lot of challenges with the implementation process. So we're kind of, you know, one of the first reports to be using this data, and have been working very closely with the Office of Equity and Inclusion, OEI, to make sure that we meet their guidelines and meet their reporting requirements. So that's the reason why there are still a few things that are kind of in draft form. But I think that's a really important process, because there's no way for folks to anticipate all the ways that changing this huge system of how we report race and ethnicity data is going to be impacted by things like our diversity report. So you received a cover letter that just kind of explains this with the report, and we hope that you'll kind of see those two things as going together right now, because this is still a draft form. Can you change to the next slide, please, Jamie? And then, so we have three next steps. We would, we plan to submit this draft to the Office of Equity and Inclusion for review. We've been in like continuous review with them, but just kind of to have a final review. We'd like to submit this draft to OHA leadership for review. And so we request from the committee to approve this draft report in order for us to advance it to the Oregon Health Policy Board. That's what we're hoping for today. And you can go to the next slide. And here's our contact info if you have any questions. So right now it's 11:55. We have on the agenda to have questions until 12:10, I will mostly hand that back over to the team to answer questions. So thank you for your attention for this and for all of your questions that have already been dropped in the chat. You can ask them in the chat or raise your hand. And I'll pass it back to Andy.
Thank you, Piper. So I think at this point, as Piper said, if you want to have question A or question and answer right now, we're happy to do that. If you want to go to discussion or motions, votes, etc., it just depends on your need right now. But I'm happy to answer questions in this period or address some of the things that were in chat if that's appropriate. Up to you all as a group.
Yeah, I think we'll go, Andy, we'll go to questions. I know Bhavesh has his hand up.
Sure.
Hey, thank you. And thank you, Andy and Meredith, for a great presentation. A couple of questions I have that I noted. First one was regarding the increased diversity in upcoming younger age groups. It may be also interesting to break that down further to see if that is happening in only certain sectors of the healthcare population, because we want that to be representative across the board in different parts of our healthcare professions. And it may be that folks are attracted to one particular part of that, and we're not seeing enough in other parts. So that would be interesting for us to evaluate further if you can do that. And then my second question was related to the percentage of usage of the language in the area by different folks who represent that they can speak a certain language. For some folks, who were speaking Spanish, they were using 80% of the time, but for others, they were only using it 2% of the time.
Mm-hmm.
And is that because they're not in the area where they need to be? Or, everyone's entitled to be wherever they want to be. But the areas where those particular populations exist, that tells me that there isn't a provider in those areas that might speak their language. That's what it infers for me. Those are my two comments. Thank you.
Sure, thank you, Bhavesh. And I think so. I think it's a very worthwhile idea for us to look through the age cohorts by occupation, by specialty group. We can definitely do that. I think one caution we're going to probably run into with that is that we don't have all of the licensed areas surveyed yet in this way. We can look at age cohorts probably across Real D and non-Real D without too much issue, but we'll just have to be aware of that. The other is that in most of the graphs that we've shown here, we've kept classifications at a level where we're not running into issues with small numbers very much. And I think one of the things that we have to be conscious of when we get to estimating or drawing conclusions with split populations like that is that, if we have a occupation that only has 1,000 people working in that occupation in the state, and we start dividing it out into racial and age subcategories, we quickly get into situations where we have 1 or 2 people in a particular category, and we're hesitant to report that, and we have guidelines around not reporting that within OHA. So we'll work on that. I don't want to make grand promises about it, but I think that's a good idea for us to examine. I will say on the language slide that Meredith presented, and this is not at all Meredith's fault, but the graph that is in the report shows a different array of how many folks have reported using that language. graphic that she showed is a older one from an older draft. That's not her fault. That's on me. But it's more uniform across languages than what's shown in that older graph. So I would just direct you to the report. I think it varies a little bit, and I think you're right that there probably are some opportunities to put people into situations or to use telehealth situations or something like that so that folks can communicate with clients who really need particular language access. But it's not quite as stark as what was shown in the presentation.
Thank you so much.
And Andy, Paul had a question actually, Paul, did you have a question in the chat? And then I know Ian had one as well.
Yeah, I did. It's just a sort of back to the other thing I mentioned before. There are some places where the numbers are very, very small, and either it makes a percentage an unstable figure. One person comes or goes, and it makes a huge difference in the percent. Or where the rounding makes it looks like there's no one in Southeast Oregon that's doing interpreting because it's rounded to 0. My concern is just that if there's some way to display that in the graph, rather than have it be, a footnote in some other document, so people won't be misled. Because I can see somebody kind of zeroing in on something and saying, wow, that's a big deal there, but it actually isn't that certain. See, I don't know if you can do that in Tableau or what, however you did these beautiful graphs, which by the way, are really well done. Nice job.
Thank you, Paul. And so I think the dashboard that Meredith presented that data from, I will say that if you go to the dashboard itself, it has in as close as we can get to sort of big biohazard radioactive labels on a dashboard as you will see for us, that it's trying to get across the message that this is sampled, that it has a relatively small rate of sample response, so that things like that hopefully don't come across as a message that we've just got no availability in those areas.
Okay. All right. Thanks.
And then Ian, did you want to go ahead and ask your question? I know it's in the chat, but I'll let you verbalize it if you would like.
Sure. So I want to reiterate, great work. The visualization work is really clear and clean. Appreciated. But I did want to know if there's any plans to move this data model into the provider incentive program data. It just seemed like that would give us a lot more access into being able to really start addressing the racial equity question in provider incentives.
I think maybe Mark is better equipped to answer that than I am, but good question. Thank you.
Perhaps, although I think Leah and Neelam are best able to speak for the program. I know generally, yes, our intent is definitely to move to a RealD format. We thought we were starting with that, and we really did not in the last year or so. But Leah and Neelam, anything else you'd like to say other than yes, we are definitely intending to move to a RealD data collection. Okay, maybe not. But Ian, the short answer to your question is yes.
Thank you, Mark.
Any more questions from committee members? All right, I am not seeing any hands up. So committee members, I think we would like to get a vote on this report. We would need a motion and a second, and then we will vote on this. If I could get someone to make a motion. And Andy, if correct me if I'm wrong, so we'll take a vote on this today. And does it go to the Oregon Health Policy Board next?
Yeah, so historically, so this is a deliverable to you as a committee. The Oregon Health Policy Board, we will schedule to deliver an informational presentation to them. It's not a product that's required to them by rule or statute.
Okay, perfect. So if there's no other questions or discussion, committee members, could I get someone to make a motion, please?
I'll move that we approve the report as presented.
Second.
Second. Okay. Once again, the virtual hands, the thumbs up, the real hands. If we could get a vote and approval. Okay. Any opposed? Any abstains? Okay. Motion passes. Oh, I'm sorry.
I just do want to check with, Coy has, you have your hand up and,
Oh, I'm sorry. I didn't lower it from my raise, so.
okay, great. That was a vote to adopt.
Yep.
Okay, thanks.
Thank you. It's very easy to forget to put your hand down, and sometimes even the thumbs up takes a little while to get down. So thank you. Okay, if nothing else, the motion passes and the report is approved. Perfect. Thank you all, and thank you to Andy and the whole team for this presentation. It was very well done. I appreciate it.
Thank you, Laura. Thank you, committee members. I just want to give thanks and kudos, even though he didn't speak today, to Derek Reinke, who was our interim manager during this process and really helped this report come to the point that it is. So on his outgoing meeting with this team anyway, thank you, Derek. But thank you, committee.
Great job. Thank you very much. Okay, it looks like our last team agenda item is our legislative update, and I believe we have Ashley, who is our interim government relations manager, and Phil here, and I am Matthew Green, I believe, are here to give our legislative update. And I will let whoever wants to take it away go first. Hi, Ashley.
Sure. Hello, nice to be here today. Hello, everyone. Ashley Thurstrup, she, her. I'm the interim government relations director at OHA. And today what we're hoping to do very briefly is give you some context about the legislative, upcoming legislative session, the environment, just share with you a little bit about what is known now in terms of the OHA legislative agenda. We don't have all of the information back from the governor's office about what will be in the approved budget, but we will share with you what we put forward and then what we know for sure today. And then we also have pulled together kind of an initial poll of healthcare workforce legislation that you might be interested in tracking. So we can go through that as well. We'll try to save some time as well to take any questions or have some conversation with you all too. So could someone pull up our slides? That would be great. Thanks, Jamie. All right, so next slide, please. And we have the wrong year there. It's 2023. Lost a year. Great. So this next slide, and you all will have this in your packet. I believe it's going to be sent out after the meeting, so you have our updated information. But this just shows our entire team, as well as the portfolios of the folks who are our senior policy advisors working in this area, and you have their contact information. So feel free to reach out anytime if you have questions about legislation. And today I am joined, I would love for my colleagues to introduce themselves, Matthew Green and Phil Schmidt, who both work on the government relations team. So Matthew, I'll pass it to you first.
Yeah, so I'm Matthew Green, do a lot of the communication work and focus on budget and a little bit of a catch-all of everything else as well. As Ashley mentioned, you can contact any of us if you're not sure who to reach out to, and we'll get it to the right place.
And I'm Philip Schmidt. Everyone calls me Phil. I use he, him pronouns. And as you can see on the screen, it might be a little small, I work with the Health Policy and Analytics Division along with Medicaid. And the workforce program is within Health Policy and Analytics. So I'm often working with the good folks that you all work with. I'm happy to be here today. Thank you for having us.
Great, thank you. If we can go to the next slide. So a bit about OHA and the government relations team. So our mission and goals are really to prepare OHA to participate in the legislative session, to coordinate responses to legislature, to support our community members, stakeholders, and important partners in timely information and consistent delivery across our divisions for work that we're all trying to do together during the legislative session, and to really guide our agency's efforts to implement policies that are centered on our 2030 goal of eliminating health inequities. And here you'll see year round, we're working on developing priority policy areas, legislation with partners, and that is something that we'd love to work with you all on in the future. And then translating, coordinating, facilitating, and leading our policy goals as it comes to implementation. And of course, advancing the triple aim is a big part of that as well. Next slide, please. So I will emphasize again that the legislative themes that you're going to see here in the presentation today are OHA's 2023 legislative themes. We are staying in line, as all 8 state agencies do, with the governor's priority and the budget, and that information has not been provided to us quite yet. It's due in statute by February 1st. We think we'll hear back earlier, and we'll have a lot more information to share at that point about what will be in the governor approved budget and our policy option packages that we put forward. But we did provide you the full list so you can see everything that was requested by the agency, as well as legislative concepts that have already been approved and what we call greenlit. So we'll talk about those today. And the 3 priorities of the governor that's been made very clear in lots of different ways is that she'll be focusing very closely on behavioral health, housing, and education. And then also working very closely with state agencies to develop more efficiency and cross-agency alignment, and then bridging, of course, between urban and rural communities as well. So our legislative themes are really around building health equity infrastructure, implementing health equity, responding to our post-pandemic public health system, making sure that that's still robust, and continuing to learn from what we have been through over the last several years. State hospital operations, shoring up that very incredible, important system. Medicaid and behavioral health system accountability, very important as we're moving through the implementation phases now with the last behavioral health package that passed in 2021. And then implementation of the 1115 waiver, first of the kind in the nation, and the health policy improvements that go along with that. And then some legislative fixes that are important for moving forward. So with that, I'm going to pass to Matthew to get into some bills.
Okay, next slide. And I think as we go through this, we'll focus on some of the ones that we think you might be most interested in, and skip over some of the others more quickly. And in particular, also that I want to highlight that we've put some things in green here. Green means the governor's office, by which I mean the new governor's office, has taken a look at them, and the green legislative concepts are officially going forward. The ones in blue are not determined yet. So they're not rejected, they're not approved, they're just in limbo at the moment. The governor's office is reviewing them. It's possible they will go forward, it's possible they will not, or they will be changed, or possibly a legislator instead of the governor will put forward this bill or something related to it. So we're not sure. We've presented these to the governor and we're waiting to find out. So the first one, this LC 440, relating to Real D and SOGI, obviously you're aware of these issues. This is a clarification that the information is confidential. Because this information doesn't count as medical data under HIPAA, it's not considered confidential under current rules, and so it could theoretically be released as a public record. And so this is to clarify that won't happen. The next one, LC 450, is about advisory committees. You being on advisory committee may be interested in this, because this is part of an effort to address something we've heard from a number of committees, that it can be difficult to participate. We sometimes do not get diverse participation because of the time commitment and the cost associated with that. The cost of taking time off work, of transportation, of childcare, perhaps, of different costs associated with it. And especially for people who may be low income, for example, who may be members of Oregon Health Plan. And therefore, we want their voice very much in this conversation, but based on their financial situation, it may be more difficult. So this is primarily starting out looking at making sure that we can compensate members and reimburse all of the members, in addition to some of the things that are already in current law, and also look for other ways to increase diversity on these committees. And one of the issues that comes up is the impact on their actual eligibility for things like OHP. So that's one of the issues we're working through, but that's the general goal of this one. So next slide. Oh, I'll cover these real quick, and let's stop me if you want to know more about them, but I'll just cover the green ones in particular here. These are some of our public health bills, and that first one is about flu vaccinations. Right now, pharmacists can give flu vaccinations if you are 7 years of age or older, which means a family that has a child who is over 7 and a child who is under 7 has to make one trip to the pharmacist and then make a separate trip to a clinic somewhere to get their youngest child vaccinated. And so we're trying to avoid that. These are for pharmacists who are already trained and approved to give vaccines in general, but loosen up that restriction. And this has nothing to do with COVID. This is only for flu vaccines. I saw a note about the dental pilot project program, so I'll mention that. This program, the pilot project program, this is not specifically the pilot projects themselves. This is the authorization for OHA to run some pilot projects, to basically adapt some of the rules about reimbursements related to dental care in order to try some things. And particularly it focuses on ways to serve underserved communities, underserved populations. And the idea is that it can try some things out and can lead to later legislative changes that make those changes in things like what different levels of dental training and credentialing can do in different settings, things like that. It's happened a couple of times that legislation has passed based on this one. The program authorization itself has a sunset clause, and it's going to end, I forget, the end of 2024, I believe. And so this is just to make it permanent so we can continue to do that. Then the LC 435, death with dignity, this is based on a lawsuit. This would require that, well, it was ruled unconstitutional that there can be a residency requirement for a patient, that only Oregon residents can be served as a patient under the Death with Dignity Act. So we need to remove that based on the court order. This does not change anything regarding the physician. The healthcare provider still has to be credentialed in Oregon. So that would be, that's all of those. And you can flip to the next one. I believe Phil's going to take it over. You're on mute.
Yeah, thank you. As you can see, the three of them that are here have not been greenlit. But to briefly describe them, we're proposing beginning the process of moving the Oregon Health Insurance Marketplace away from using the federal platform to using a state-based platform. And it would take several years, but we are confident that if we move in this direction, we'll have a lot more access to data and actually be able to meet people where they are as they transition often between Medicaid and the marketplace and back and forth. This really came to light at the end of, well, during the pandemic, but as we've been planning for the end of the public health emergency, we're trying to make sure that anyone who is on Medicaid that no longer qualifies lands in some form of coverage, and a state-based marketplace is really integral in doing that well. We also will be focused on the Medicaid waiver implementation. This legislative concept is a placeholder, and alongside the Medicaid waiver implementation, we're also going to be working through the redeterminations process, which is checking the eligibility of everyone who's been on Medicaid throughout the pandemic. And as I said at the beginning, to make sure that if they're no longer eligible, that they make it onto some form of coverage. We achieved the highest coverage in our state's history during the pandemic, and our goal is to keep everyone covered who was covered and reach more people, frankly. We can move to the next slide.
And cover these real quick. The payer parity relates to the 988 system. We have heard concerns. Well, the system's up and running in general, although there's some funding later to add to it. But we've heard one concern that private insurers are sometimes not covering the actual services provided, so it ends up being covered by community mental health centers, basically through the county and state tax funds paying for it. And so this would just update that mandate to, well, everybody pays their share of the costs. And then the aid and assist bill, this relates to the state hospital. You may know that the state hospital is under a court order around discharges of patients who've been at the hospital for a certain period of time. And the solution in particular revolves around doing as much as we can to find other places for people to go other than the hospital. And there's a series of recommendations in a report that was submitted as part of the court order. And so this bill simply carries out those recommendations. So next slide. And this is the giant list of all of them. And I don't expect you to read them all or memorize them, but I'm putting in the chat a web page for the government relations site, and it lists, it has all of these on it. So if you're interested in any of these, you want to look into them more, read the actual text of the LC. Some of these have become bills already, but not all of them yet. And there's an explanatory statement around them. Again, some of them have been approved by the governor and others are waiting. So next slide. So we're getting to the budget. How much time do we have? We have a little bit of time to mention a few of these things.
I think we might just want to go to slide 16 just to show the healthcare workforce kind of related bills that we're seeing. Because everyone will have this.
If you're interested, on that same government relations site that I just listed, if you scroll down just a bit, you'll find a heading that says 2023 budget requests. And so you can find information on all of these POPs, the budget requests that we're flipping through really fast. You can read them at your leisure. So this page, a whole bunch of bills in tiny print. This is all of the bills that we have seen so far. This is not exhaustive. This is not a complete, well, it may or may not be a complete list. We're going to look around. These are all the ones that we've seen so far since they were introduced on Sunday night that look like they have something to do with healthcare workforce. There are about 1,800 bills, and so far we've got, what is it, 9, 10 of them that talk about workforce and some others. There may be others introduced later in the session. We have not done an analysis of these. We've not prioritized them or know much about them other than that they exist. If you want to go to the legislative site, you can look up and read the actual text of all of these. We're going to look at all of them in more detail in the days to come, and I think some of staff around OHA are doing that right at this moment, but we do not have a lot of information. I see a couple of questions. Can't guarantee that I can answer them. Anything about nurse staffing? Yeah, there is at least one at the bottom of 5. About students to become licensed practical nurse or registered nurse.
Yeah, and also Matthew, we do know that nurse staffing is going to be a really significant conversation during the legislative session. And while I think there's another bill that may address sort of advanced scheduling for nurses and others introduced by Rep. Nelson. But I think there's really going to be a significant conversation, and I don't think that the bills reflect that at this point in the initial drop, but it is something that we'll be tracking and providing data and information for. But yeah, we don't see a bunch of bills or a specific bill on nurse staffing that would sort of address the breadth of that conversation at this point.
2755. I don't think there is a 2755 yet. Is that, you sure that's the right number? Or that might be the LC number. It's not a bill number.
That's the LC number.
Okay.
It was a bill that Oregon Dental Association brought forth regarding dental workforce. And it also added funds to the incentive fund for dental providers.
Is it 441?
Is it 441?
Is that what it is?
I think that's it, John. Is that it?
I just have the LC number, Laura.
Yeah, that might be it. That might be it, John. It's 441, SB 441.
And unfortunately, there is no good actual cross-reference of LCs to
Yeah,
bill
no,
numbers.
that's okay.
It just doesn't
I think
exist.
that might be it.
Okay.
Thank you.
We do think that there'll be quite a bit of conversation also about, dental programs, incentives, et cetera. So
that makes me happy.
So that is the end of our presentation. We're happy to answer questions. We're going to be looking at all these bills, as I say, in much more detail over the next few months.
I know, sorry to interrupt. I know Paul had a question. He said, is there any follow-up arising out of Measure 111 passing?
Measure 111. I'm not sure. You happen to know that, Ashley or Phil?
I don't. It's a good question. And I think this is an, if we probably would have been able to be here in a week, we'd have a lot more information. But since bills all just dropped, we're in the middle of analyzing about 2,000 bills, so it's the information yet.
Yeah, I haven't actually seen, but like I said, we're just looking through them. I'm guessing there's somebody in there has put in a bill to try to operationalize Measure 111, but I haven't noticed it yet. It's probably in there somewhere.
No, that's okay. Any other questions for our government relations team? I'm not seeing any hands or thumbs or, okay. Well, thank you all very much. This was very informative. I'm hoping that we can, Mark, I don't know, hoping we can have this maybe as a standing agenda item when we have our meetings, possibly. So thank you all very much. And with that, we're on time for closing our meeting. I think, we'd like to have our meeting on February 8th to talk about the report. We will work with Mark and staff to send out some sort of Survey Monkey to talk about the potential action items. And we'll do that in February. And then our next scheduled meeting is March 8th, I believe, but more to come on that. So thank you all very much for joining us today. We appreciate all of the input and all of the discussion and the presentations. And thank you all again. I'm happy to serve as chair for another year and have Paul as my sidekick vice chair. And we will see you all in February and we'll get the information out for that. So thanks everyone. Our meeting is officially adjourned and we'll see you all in February. Have a wonderful rest of your week.
Thank you, you too. Bye.